Hello, and welcome to Adverse Events and Harm Reduction. As you know, the cannabis plant is a treasure trove of healing, as we've already discussed. But just like all good things, there can be risks with cannabis use. And so, in this module, Dr. Russo is going to cover extensively what those risks are and how to reduce harm. Dr. Russo?
Thanks so much, Nisha. Welcome once again. Here are introductions, which we'll let you read separately. So the objective of this module is to examine cannabis-associated adverse events, commonly called side effects, noted in cannabis clinical studies. We will compare and contrast recreational versus therapeutic use and highlight the differences between smoking and oral administration. It is hoped that these distinctions will clarify salient distinctions in cannabis delivery with their many implications for patients and their families. Disclosure, probably don't need this. I think that everyone realizes that almost nothing we're going to discuss is FDA approved. That would apply to Marinol, perhaps for certain indications in Epidiolex. So this is all for educational purposes. And if various therapies are tried using cannabis-based medicines, the outcomes will vary. I would like to read this. There is a world of difference between recreational studies of cannabis, wherein the intention is to attain intoxication, release, or an altered state of consciousness, as compared to its therapeutic application, wherein the intent is to attain symptom relief at much lower dosages without adverse events, including psychiatric symptoms. Now, we're going to be really going hither and yon in space and time, different topics. This is a very broad topic, and this will be a long presentation. But I want to begin historically. And the first scientific systematic study of cannabis was this, the Indian Hemp Drugs Commission report, which the British Crown based on information from throughout India. And I'm just going to highlight specific areas. Quote, in regard to the physical effects, the Commission have come to the conclusion that the moderate use of hemp drugs is practically attended by no evil results at all. Speaking generally, the Commission are of the opinion that the moderate use of hemp drugs appears to cause no appreciable physical injury of any kind. The excessive use does cause injury. As in the case of other intoxicants, excessive use tends to weaken the constitution and render the consumer more susceptible to disease. Uh, Slight point, excessive use of these drugs does not cause asthma. It may cause bronchitis, mainly through the action of the inhaled smoke on the bronchial tubes. So let's place this in context. There was a lot of hysteria about this drug and what it did to people, and what they've said here really goes against the conventional wisdom of the time. Everything they've said here remains true today, some 130 years later. More from the report. The Commission have come to the conclusion that the moderate use of hemp drugs produces no injurious effects on the mind. This is of particular interest because psychiatric sequelae have always been the claim in relation to cannabis harms. Moderate use produces no more moral injury whatever. Again, there have been links attempted in the past to tie cannabis use to crime, but these largely have not been borne out except with respect to the substance itself being illegal in many jurisdictions. Another quote, the injury done by the excessive use is, however, confined most exclusively to the consumer himself. The effect on society is rarely appreciable. One would then question the great effort putting into making these substances illegal, but that's a political discussion. Jumping ahead, in the 1970s, the National Institute on Drug Abuse, part of the National Institutes of Health of the US, commissioned a variety of studies in cannabis using countries to assess the effects of chronic use. In the study, they looked at 60 adult males that they put in the hospital to study. They were averaging 3 spliffs or large joints a day for more than 10 years. Now, the material varied in its concentration, but was up to 10.3% THC, which would have been pretty good for that era. Um, the average was low, but this may have been offset by high rates of usage. There were no significant differences between these people and folks who were not exposed to cannabis with respect to electroencephalograms or their blood work. There was a slight downward trend in the breathing, forced vital capacity, and forced expiration volume in 1 second, but this was not significant either. Of greatest import, there was no significant difference in neuropsychological testing, except that users actually had an increase in the waist digit span, a little memory test. So that may be counterintuitive, but that's what they got. Similarly, in Greece, they looked at hashish users of greater than 10 years, 60 of them. Hashish was relatively low by modern standards, but would certainly be enough for intoxication of 4 to 5%. And as was habitual there, it was mixed with tobacco. There was an increase in bronchitic symptoms, could be due to the tobacco in particular. Not much in the way of EEG changes. Again, on neuropsych testing, users did better than controls on waist similarities, digit symbol substitution, and verbal IQ. To quote, these observations do not provide evidence of deterioration of mental abilities in the hashish users. And from Costa Rica, 41 subjects for more than 10 years, average of 2 grams a day. Material was up to 3.72% THC. There was some bronchodilation noted, but no immunologic or endocrine changes that would affect testosterone levels or fertility. On neuropsych testing, quote, we failed to uncover significant differences between user and non-user groups, even in those subjects who had consumed cannabis for over 18 years. As you might expect, these were not the results that the National Institute on Drug Abuse expected, and these studies were stopped. Additionally, these 3 books that you see here disappeared from library shelves in this country, and it took me many years to gain copies of each one. Also from the same work, Melanie Dreyer, who went on to become nursing school dean, did her doctoral work in Jamaica. She wrote this book, Working Men in Ganja, that showed that this actually increased the ability of people to handle the heat and work. And this was a major refutation of the so-called amotivational syndrome attributed falsely to cannabis. Additionally, she did studies showing that Rastafarian mothers who smoked these large spliffs during pregnancy but did not drink or smoke tobacco had children whose motor milestones were advanced over control women's children. We're going to be coming back at various times to the study that you see here. There was a program called the Compassionate Investigational New Drug Program that had at some time perhaps up to 16 members. Back in 2001, we got them together, the people that could, and we studied extensively how 4 people who had gained access to cannabis through the US government by proving that nothing else helped them, what kinds of reactions they had on various testing. So this is the demographics of the patients. You see that 1 had glaucoma, 2 had very painful musculoskeletal disorders, Neil patella syndrome, and multiple congenital cartilaginous exostoses, and 1 with MS. Now, they were using very high amounts of what would now be considered low-grade cannabis, but certainly represented a high intake of THC. And likely there was no CBD in this material, and it was pretty much devoid of terpenoid content, as we've seen from subsequent testing, but also the fact that there was very little associated odor for this material that had been stored sometimes for many years. This is a listing of all the tests we did, and we'll, during this presentation, be going to various of these to get more detail. Now we're going to skip ahead to a more recent study, Edie et al., under the direction of Caroline McCollum, looking at neurocognitive impairment with medical use of cannabis, as was for the large amounts of smoke material in the prior study. In this survey, they looked at clinical studies of cannabis, either for indications of chronic non-cancer pain or spasticity for the 20-year time span to 2019, and that had neurocognitive testing as part of their programs by the PICOS criteria that you see at the left. So the patients were, as we mentioned, they had to be on cannabis or cannabis-based medicine, and looking at the outcome and studies types were randomized controlled trials and other clinical trials. They had inclusion criteria, again, limited to these two indications. There had to be safety studies associated, studies in English were excluded, et cetera, et cetera. Out of many papers, they selected 6 randomized controlled trials and 1 observational trial that fit all the criteria. They had this very nice figure here that looked at modifiable and non-modifiable factors. They pointed out that prior studies suggested possible impairment with THC serum levels of 2 to 5 nanograms per milliliter, but these were very inconsistent. And this could be due to genetic factors or that people became tolerant. As we've mentioned previously, people quickly become tolerant to the psychoactive effects of THC, particularly in medical use at lower doses. They pointed out quite rightly that some conditions produce impairment in their own right. Under these circumstances, interventions with THC might actually help. An obvious example would be if someone's so stiff that they can't move well to drive, reducing their spasticity could make them a better driver. And then there were other factors, such as whether there were CBD content, other substances that might reduce THC-associated side effects, such as the terpenoids, etc. And whether they had other sedating substances on board, whether it be alcohol or other medication. Summary of findings is on the left, and different people had different minor impairments. But to quote, in all the studies, there was no difference between any of the THC groups and placebo in any neurocognitive measure after 4 hours of recovery. This was true no matter what the dose of THC was. Also, quote, nevertheless, the trends that emerged among these medical cannabis impairment studies compared to the recreational data support that medical cannabis patients do not have the same duration or degree of neurocognitive impairment as recreational users. Subsequently, McCollum et al. Developed this sort of guideline paper, what they call the clinical framework for assessing cannabis-related impairment risk. If you are recommending or prescribing for patients and want to have a good idea of the factors that you should ask about or assess in your testing, this is an excellent paper to read. We want to know how long they've been using cannabis, what kind of products, what frequency, whether they have other risk factors, such as other drugs or alcohol, and other factors that mitigate this, like having CBD content. And just a listing of different adverse events that might be associated, of course, most notable in the neurocognitive sphere, but also more somatic side effects, mood changes, or cardiovascular problems. Quote, common cannabis-related impairment adverse effects are not experienced by the majority of patients using medical cannabis when the THC starting dose is low and titration is slow. Also, quote, there is an indirect potential for impairment with moderate to high doses of CBD when taken with other CYP3A4 inhibitors, specifically with combination of anti-epileptic drugs, clobazam with CBD, where there's a drug-drug interaction that increases N-desmethyl-clobazam levels in the blood, producing sedation. This is a study that I did some years ago. And to my knowledge, this is the first study that ever compared adverse events associated with chronic use of smoked cannabis with that from oral mucosal administration of Sativex and nabiximols. And so in the warm colors, you see two studies from Holland, the Dutch and Marafarm, and one from the medical program in Canada. And these were all people that had been on cannabis, in this instance smoked, for some long period of time. The nabiximols or Sativex data came from patients in safety extension studies of clinical trials. So none of these patients were any longer blinded, but these were the reports of side effects. Now, what immediately becomes apparent is that the warm colors are, in almost every instance, are higher than the cool colors, meaning that there is double or often triple the number of adverse events associated with smoking as compared to oral mucosal administration. The one outlier is more dizziness with Sativex and nabiximols. Now, that may have been due to an early and rapid titration that was later controlled much more closely. But still, this is a striking example of the difference between oral mucosal or oral administration as compared to smoking in side effects that ensue. Dr. McCallum and I, a few years ago, wrote this article because there really was not one by 2018 on cannabis administration and dosing. Couple of figures from that. Again, to look at the Sativex and nabiximol safety profile. The reason we're looking at this is this is the only cannabis-based medicine derived from the plant, aside from Epidiolex. The only one that contains THC, and which is approved in 30 countries by regulators, although not in the US. Now, why I wanted to include this is the initial studies in multiple sclerosis were done with a more rapid titration and higher allowances in the number of sprays per day. The study in red was the pivotal study that led to the approval of Sativex for spasticity in MS, now in 30 countries. And you see a distinct difference, and that is because by this time it was found that higher doses, more sprays per day, resulted in more adverse events, but not an increase in efficacy. So this was capped at 12 sprays per day, which would be 32.4 milligrams of THC and 30 milligrams of CBD. But to go through each, you see that dizziness about doubles with the higher doses and more rapid titration. Somnolence almost reduced by half with slower, dry mouth, and vertigo, also quite clearly better with a lower and slower dose titration regimen. Again, from our paper, looking at the most common side effects that are well known to everyone: drowsiness and fatigue. This is with cannabis in general. Dizziness, dry mouth, cough, phlegm, bronchitis, only applying to smoking. Anxiety, nausea, and cognitive effects. Also common, euphoria, blurred vision, and headache. Less common, or even rare, orthostatic hypotension, toxic psychosis, depressed mood, discoordination, persistent tachycardia, hyperemesis issues, or diarrhea. And we'll be considering most of these in much more detail. What is toxic psychosis? Well, this is what can happen, particularly to a naive individual who's exposed to too high a dose of THC, and they become paranoid, delusional, may even hallucinate. Now, it's well established in the literature with Marinol that even low doses, as low as 15 milligrams, could cause this temporary toxic psychosis um, with as low as 15 milligrams exposure. A specific study um, was done, Sellers et al., um, with Sativex. This was to examine QTC intervals to ascertain whether use of cannabis at extreme doses would produce any prolongation of the QTC interval that would make someone more susceptible to cardiac dysrhythmias. Um, there were something like 4 patients out of over 200 exposures at 18 sprays twice a day where there was a toxic psychosis. That number of sprays would be in the 48 milligram of THC range and is too much for anyone at one time, particularly a naive patient. Now we're going to talk about cannabis and cancer, and again, we'll be going in and out on this. It was noticed that with smoking, that various pre-malignant changes were noted in the lung, affecting the cells. There was also a claim of increase in head and neck cancers, not borne out by subsequent testing. Um, if we return to the health effects of cannabis and cannabinoids from the National Academies in 2017, um, they looked at this issue. There was moderate evidence of no statistical association between cannabis use and lung cancer and head and neck cancers. So this is looking at all the subsequent literature. There is limited evidence of a statistical association between cannabis smoking and non-seminoma type testicular germ cell tumors. Now, our friend Donald Abrams was one of the experts on this, and he quite rightly pointed out that who gets testicular cancer? It's young men. Who smokes the most cannabis? Also young men. So this is an association, but it does not definitively indicate causation. Going on, there is no or insufficient evidence to support or refute its statistical association between cannabis use and esophageal cancer, prostate cancer, and a whole list of other types of cancer. As of 2017, this is pretty much the definitive word. How about cardiovascular issues? On the con side, cannabis clearly, when THC is too high, can produce tachycardia, rapid heart rate, or postural hypotension, meaning feeling faint or passing out when you get up too fast. Back in 2001, Middleman showed a rate of myocardial infarction increased 4.8 times in the first hour after cannabis smoking. There was also a case series. THC metabolites were found in 6 young people who apparently had cardiovascular deaths without evidence of other drugs. I put this in the meaningless category because we know well that various athletes, particularly basketball athletes, can suddenly have cardiac arrest and may have nothing to do with cannabis. On the pro side, there's a rapid tachyphylaxis, development of tolerance to tachycardia and hypotension, and regular use of cannabis products therapeutically without loss of clinical efficacy. Stephen Sidney actually, it was an epidemiologist and looked at extensive data. We'll get into more detail. Um, he felt the risk of MI was likely greater due to engaging in sexual intercourse. Um, he also pointed out that the study claiming cardiovascular deaths in young people didn't account for other drug usage. He also noted therapeutic benefits that CB1 agonists like THC prevent hypotension and endothelial dysfunction after heart attacks. So subsequently, Sidney looked specifically at cardiovascular consequences of cannabis usage. This is a really extensive survey, 65,000 plus patients and rates of circulatory disease for cannabis users compared to non-users. And, quote, the risk of circulatory disease or death was neither increased nor decreased by marijuana use relative to non-use of marijuana. That means never users or experimenters. The study did show a decrease in time until chest pain in patients who had angina who were smoking, and obviously caution was advised in this population. Roth again looked at this issue in 2005, and again, there were pros and cons. With respect to the lungs, inhaled smoke has carboxyhemoglobin increases and possibly increased risk of heart attack in the first hour in the susceptible individual. Brain changes lead to rapid pulse, increase in blood pressure, or actually lower blood pressure if the dose is excessive. On the immune system, there actually may be some benefits on reducing risk of cardiac fibrosis or even reducing atherosclerosis. There was a lot of publicity when this came out, this study in 2005 from France, a thing called cannabis arteritis, which has never been established as a standalone diagnosis. This is what it looked like clinically, and here's a blockage in an artery. This study was produced in France, and at that time, basically the only way that people use cannabis was concomitantly with tobacco, and it's highly likely that these are people with Raynaud's disease or other cardiovascular issues. Back to the national academies. Cardiometabolic risk, there is limited evidence of a statistical association between cannabis use and triggering of heart attacks, strokes, or bleeds in the brain. And there seems to be a decreased risk of metabolic syndrome or diabetes. There is no evidence to support or refute a statistical association between chronic effects of cannabis use and the increased risk of acute myocardial infarction. So much as Stephen Sidney had suggested almost 20 years before, the public health implications of cannabis use really don't show an increase in MI. In 2015, I was invited to do an editorial on cardiovascular risk that you see here. Um, there was subsequently another epidemiological study that found the cannabis risk of myocardial infarction was at 0.8%, which was a lower population attributable fraction than that for air pollution. Now, that may sound frivolous, but this has come up twice now in the literature. During this interval, I was the pharmacovigilance officer for the Sativex studies at GW Pharmaceuticals. And so I had access to all the data throughout the 14 years of the program at that time. Um, Cardiovascular adverse events were seen occasionally when there was a rapid titration up to 130 milligrams of THC per day, which was allowed in the early studies. Um, but it was rarely at the more moderate dose limit that was established subsequently of 32.4 milligrams per day, where there was less than a 2% incidence of any kind of cardiovascular side effects, and the rate of orthostatic hypotension, people passing out when they stood up, was 0.1 to 0.2%. And this included some people quite elderly and were on polypharmacy. So yes, it happened, but was quite rare at that point. Um, Once again, the study to which I referred, Sellers et al., and which I also took part, at doses up to 97.2 milligrams of THC per day, divided in 2 doses, Sativex produced no QTC interval or other conduction abnormalities in the heart. And then some very interesting data out of Israel using ultra low doses of THC, 0.002 milligrams per kilogram in mice, seem to be cardioprotective in what they call preconditioning experiments in an animal model of myocardial infarction. And very recently, this study has just come out and it's gotten some attention. They looked at data from 27 US states and 2 territories over 4 years in patients 18 to 74 years of age, 434,000 people. Quote, among never tobacco smokers, daily cannabis use was also associated with myocardial infarction, adjusted odds ratios 1.49, stroke, AOR 216, and the composite of coronary heart disease, myocardial infarction, and stroke, AOR 1.77. Quote, patients should be screened for cannabis use and advised to avoid smoking cannabis to reduce their risk of premature cardiovascular disease and cardiac events. Let me stop there and take a breath, as I hope you will too. This is cannabis smoking in general, and this would be a vast majority likely adult use. This is with smoking. And this is not the situation we expect at all in lower doses, particularly with oromucosal or oral administration for therapeutic purposes. So I'm not saying this is not true, but these odds ratios are still somewhat low. Usually, public health officials get excited when that number is 2 times or more. Um, so this represents a worst case scenario. It's worth taking the advice. We generally do not recommend smoking as a method of administration to medical patients. Getting back to the lungs, Donald Tashkin for many years was the dean of smoking related issues with cannabis at UCLA. Um, and this study, particularly its title, came as a surprise. Heavy habitual marijuana smoking does not cause an accelerated decline in forced expiratory volume in 1 second with age. So people thought it would be quite different than this. But there are associated changes. These are pictures from bronchoscopy, looking at inflammation in the airways of young marijuana and tobacco smokers. And highlight on the upper right, cannabis only, and you see there's a lot of redness. So clearly there's irritation from smoking, but this hardly would be a surprise. And also cytological changes noted by Roth et al., hyperplasia, and some vascular dilatation. increase in goblet cells that provide the mucus on the lungs in response to the irritation. Um, now, Roth et al. Looked at the reasons that cannabis-only smokers would not get cancer as had been expected. And it turned out that THC actually inhibits the effect of tar in tobacco to stimulate the CYP1A1 activity. And eventually this leads to lower cancer risk. But that has been borne out epidemiologically in other studies. Going back to the chronic use study that we did with the 4 legal patients, these are the pulmonary function test results. These are percent of predicted forced vital capacity, actually a little increased, and that's expected with any kind of smoking. The forced expiratory volume is how much you can get out in a short time, but these numbers were not that bad. Interpretations, patient A, mild obstructive defect, normal but slightly prolonged forced expiratory volume, moderate obstructive defect. On the 4th patient, no obstructive defect. Bear in mind, these patients were using up upwards of 9 grams a day of material. So again, a really worst case scenario. And things could be a lot better with less smoke exposure. Looking at x-rays, there were no major findings on the x-rays. One of the patients was said to have a possible pulmonary nodule. It actually was a foreign body outside their body. So that was a non-finding. We should point out that 3 of the 4 people smoked tobacco as well. So this really was a worst case scenario. Patient B was a cannabis-only smoker, smoked the greatest amount per day, and had a connective tissue disease, but I had obvious great reduction of symptoms. Another study from 2005, again, alleging issues with cannabis smoking, asthma, bronchitis, cough, phlegm, but 77% of the patients also used tobacco, so not really very valuable in assessing the relative risk. Again, Professor Tashkin, smoked marijuana as a cause of lung injury. This is a summary of what had been seen. So increases in bronchitic symptoms, some mild airway obstruction, again, airway injury, redness, swelling, increased secretions, etc. Some increase in pre-tumor markings, alveolar macrophages indicative of inflammation, etc., but nothing truly earth-shattering. Again, an epidemiologic study of smoking versus lung cancer risk. They found 1,212 cancer cases versus 1040 age local controls. Quote, we found no positive associations between marijuana use and lung or upper airway tract cancers. Odds ratios for greater than 60 versus 0 joint years, 1.1 for oral cancer, 0.84 for laryngeal cancer, and 0.62 for lung cancer. These numbers less than 1 mean that there was a lower incidence of cancers of those types for the cannabis users. And to explain this, it is possible that such inverse associations may reflect a protective effect of marijuana. So this is not what the government expected or paid for. Another study from 2009 looked at 434 cancer patients versus 547 age, gender, location match controls in Boston. They thought that alcohol and tobacco use increased cancer risk. But moderate marijuana use was significantly associated with reduced risk of HNSCC, head and neck squamous cell carcinoma. So that put that one to rest, at least for a little bit. So up to 2017, the National Academies, there was substantial evidence of a statistical association between cannabis smoking and worse respiratory symptoms, bronchitis, etc. Some moderate evidence of a statistical association between cannabis smoking and improved airway dynamics with acute use, but not with chronic use, and a higher forced vital capacity, as we saw previously in the 4 patients in the chronic use study. They showed that cessation of cannabis smoking led to improvements in respiratory symptoms. Limited evidence of an association between cannabis smoking and chronic obstructive pulmonary disease when controlled for tobacco use. Again, that really hasn't borne out over time. And insufficient evidence of increased hospitalizations for COPD or asthma exacerbations. Now, other issues. Let's look at cannabis concentrates. This is an older study that looked at some crude extractions with naphtha, which is a petroleum distillate filled with potentially toxic ingredients. Petroleum ether, almost nobody's using that these days. Regular old olive oil and ethanol. As you might expect for this type of substance, cannabis is extracted with polar solvents. Many of these are potentially explosive or flammable. You can get a high degree of concentration with these. We really worry about naphtha and butane that potentially leave toxic residues. Even self-report DAB users, cannabis concentrates, note greater degrees of tolerance, having to use more and more to get their level of high, and the tendency towards withdrawal symptoms. I would ask the question, how high does a patient need to be to have symptom relief? The answer is not necessarily at all. One of the great findings from the Sativex program was that with intoxication, there was an increase in side effects, obviously, but also a reduction in clinical efficacy for whatever the parameter being studied happened to be. And in fact, results are often better at lower doses where people reported no intoxication. Now, there are many different kinds of vaporization, but it is not always what is advertised. Sequential photos. This is a cannabis concentrate in a vape pen. This is the coil of it before the battery is actuated. And then once it's actuated, it's red hot in seconds. There's no way that this is in a range that doesn't potentially cause unwanted problems. This was a study that was done with e-cigarettes. To be fair, this was with tobacco, but the same admonitions apply. E-cigarettes typically use propylene glycol and glycerol as propellants. When these are overheated, up to 2% can come out as formaldehyde. That is the same stuff they use to embalm people, and it is a group 1 carcinogen. The authors estimated that the risk is as much as 15 times that of chronic cigarette smoking with respect to cancer. More paraphernalia, e-cigarette or vaping product use. Some years ago, there was a mini epidemic of what is called EVALI. E-cigarette or vaping product use associated lung injury. That's a mouthful. So this is associated with serious and sometimes fatal lung disorders. It occurred with nicotine e-cigarettes, but also with cannabis products. Um, in the latter case, association was made using vitamin E acetate as a diluent. This is used because it looks sort of like a cannabis concentrate and was something to dissolve the material in. Vitamin E acetate is not toxic. It's meant to be taken orally. It was never designed to be heated in this manner. So the method is the problem more than the substance. There could be other components that contribute to form what are called ketones we have discussed in our prior module. Um, in California, this study was done in 2013, looking at pesticide residues in cannabis smoke. These were the things tested. They applied these to cannabis and then looked at 3 ways of administering it uh, from each device, a filtered water pipe, non-filtered water pipe, or glass pipe. They pointed out that there are no environmental protection administration tolerances are set for pesticides on smoke crops. Um, Pesticides and growth regulator residues are frequently found on testing from black market cannabis. The bad news is when pesticides were present, up to 70% of the residual was noted in the smoke in these machines. Subsequently, we did a study in Washington State. We've gone into this in a prior module, so I'll go quickly. 26 samples that were bought in the legal market were tested for pesticides. The majority of these were concentrates. Many of them had multiple contaminants at huge rates in the hundreds of thousands of parts per billion, so high that they were hard to study in the machines. There were 24 different kinds of agents of every class that were noted. Particularly the neonicotinoids are associated with mortality in honeybees, as we see at the bottom of the slide. These were the agents that were found, and there's details on the associated problems that they could cause. Um, uh, this study is available at ethamusa.org at the library tab for additional detail. Other issues that the National Academies assessed: immunity. There is limited evidence of a statistical association between cannabis smoking and a decrease in the production of several inflammatory cytokines in healthy individuals. No statistical association with liver fibrosis or hepatic disease in patients with hepatitis C that had daily cannabis use. No or insufficient evidence of an association with other immune issues in patients with HIV or HPV, human papilloma virus. Back to the chronic use study, again, patients routinely daily using 9 grams or more of material. We looked at lymphocyte absolute count, CD4 percentages in absolute count. All of these were within normal limits. Patient B also had increased red cells, but again, that would not be an immunological issue. We also looked at endocrine parameters. One interesting thing about cannabis smoking, acutely, there can be a lot of changes in hormone levels, but this is looking at chronic use over the period of time. So FSH, LH, prolactin, estradiol, estrone, estrogen, testosterone, and progesterone, every value in every patient was within normal limits for the age or gender. We'll have a separate presentation on cannabis in the liver because this has really been an issue over time. And actually, some people are kept off of transplant lists if they're a cannabis user, although there's no rational basis for that. What we can say is the endocannabinoid system has an important role in mediation of many physiological systems, including hepatic lipid metabolism, fibrosis, and cancer. Earlier studies that suggested that there could be scarring or pro-fibrotic effect of THC, but again, that has not been borne out, as noted by the national academies. Um, it is clear that THC has made it possible for a lot of patients to get through their chemotherapy for hepatitis C. Previously, there were a lot of dropouts due to side effects, particularly nausea associated with the older drugs. It is better now, and I believe that patients can be treated for as little as 6 weeks to get a complete cure of Hep C. Additionally, other components, cannabidiol, THCV, caryophyllene, um, probably help the liver, particularly with fibrotic issues. CBD has been associated with a decrease in graft versus host disease. Um, so there really is no valid reason scientifically that people should be denied liver or other transplants because they have positive urine drug screens for THC. Um, Looking at accidents and death, there is substantial evidence of a statistical association between cannabis and increased risk of motor vehicle crashes. Often, though, this is multiple drugs, including alcohol. Moderate evidence of a statistical association between cannabis use and increased risk of overdose injuries, respiratory distress among pediatric populations in states where cannabis is legal. No or insufficient evidence to affect all-cause mortality, as was found by Sydney earlier. Occupational accidents or injury or death due to cannabis overdosage, which frankly should be close to impossible because there's very little CB1 in brainstem centers that subserve respiratory drive. Now, really controversial areas, prenatal, perinatal, and neonatal exposure. The National Academies felt that there was substantial evidence of an association between maternal cannabis smoking and lower birth weight of the offspring, limited evidence for other pregnancy complications or neonatal intensive care admissions, insufficient evidence for an association for SID, sudden infant death syndrome, problems with development or school issues. Going back to Melanie Dreyer, uh, she had this great book chapter, also a study that was in pediatrics, looking at the so-called Roots daughters, Rastafarian women smoking ganja, but not cannabis and not using alcohol. Why did they use it? Well, um, it was to increase appetite, reduce nausea in pregnancy, help them sleep, and help them work. Um, so cannabis increased their comfort levels, may have helped their outlook. Um, and as she said, quote, not as a recreational vehicle of escapism, but as a serious attempt to deal with difficult physical, emotional, and financial circumstances. Effects on human gestation, these are the old studies. No effect on miscarriage, no effect on birth weight or growth, from Fried et al., who spent his entire career looking for developmental problems in children of mothers who smoked. In 417 cannabis-only users, there was no prematurity or birth defects. Um, there was a decrease of 79 grams average birth weight in 331 mothers with positive urine screens. That really isn't statistically significant, less than 3 ounces. 12,424 pregnancies showed no deleterious effects of cannabis when corrected for confounding factors. Now, it is true that some studies have shown low birth weight in babies born to mothers who smoked, but in general, these have been poorly controlled for concomitant drug use, particularly alcohol or tobacco. And there's been a more recent study that purported the same thing. However, this is a meta-analysis reviewing all uh, the studies that they could find, 31 in total, that examined the issue. So this carries a lot more weight. 31 studies excluded tobacco usage and other confounds. No significant differences were seen for low birth weight, relative risk 1.16, or preterm delivery, almost 1. Quote, maternal marijuana use during pregnancy is not an independent risk factor for adverse neonatal outcomes after adjusting for confounding factors. Very good. Dr. Russo did not say that it is okay for women to smoke during pregnancy. Again, we do not recommend smoking for anything. Um, however, uh, when women need cannabis to treat conditions during pregnancy, certainly there is a great deal of data to support its benefits, particularly on nausea, as occurs in morning sickness or its worst form, hyperemesis gravidarum. We'll have a lot more to say about this in another module. An excellent study from 2020 looking at cannabis exposure and effects on the infant. They did 1,001 statistical comparisons of cognitive outcomes. Scores were worse in less than 3.5% of prenatally cannabis-exposed children and better in less than 1%. Quote, cognitive performance scores of cannabis-exposed groups overwhelmingly fell within the normal range. Nice result. Again, it doesn't mean it's fine to smoke in pregnancy. This still gets people in a lot of trouble. And there are better alternatives, particularly vaporization if need be, or even better use of oral preparations. Looking at mental health, and you see the small print comes out, substantial evidence of association between cannabis use um, and association, not causation, to the development of schizophrenia or other psychoses with the highest risk among the most frequent users. Moderate evidence of a statistical association between cannabis use and better cognitive performance among individuals with psychotic disorders. Um, increased symptoms of mania and hypomania and bipolar disorder. Small increased risk for depression. Again, increased incidence of suicidal ideation, um, uh, increased incidence of social anxiety disorder. One must have to answer the question, though, is it chicken or egg? Did cannabis cause these problems, or was it being used to try and treat these problems? And those kinds of questions are rarely asked in studies of this type. No statistical association with worsening of negative symptoms of schizophrenia, limited evidence of association with increase in positive symptoms, meaning hallucinations, etc. No evidence to support changes in course of symptoms in depression or to develop post-traumatic stress disorder. So this is a hot mess, but let's sort through some of the better studies after we go through more pages of this. Moderate evidence of a statistical association between cannabis use and impairment of the cognitive domains of learning, memory, and attention, true only for acute cannabis use. Limited evidence for impaired academic achievement and educational outcomes, increased rates of unemployment, impaired social functioning, etc. Limited evidence of impairments in the cognitive domains of learning, memory, and attention. Problem cannabis use. Stimulant treatment of attention hyperactivity disorder during adolescence is not a risk factor for the development of problem cannabis use. Going on to say, um, uh, moderate evidence for anxiety, depression are not risk factors, etc. So I'll let people sort through this on their own. And um, uh, is cannabis a gateway drug? There is moderate evidence of a statistical association between cannabis use and development of substance dependence or abuse disorder for alcohol, tobacco, and other illicit drugs. Limited evidence of a statistical association between cannabis use and initiation of tobacco use, changes in the rates and use of other illicit and illicit substances. Again, please keep in mind, this is cannabis smoking recreationally. An excellent paper from some years ago by Zach Walsh and colleagues looking at cannabis and mental health, all the data available to that time. Again, neurocognition, 6 reviews of non-medical use, which we've heard about. 2 studies of therapeutic use showed improved executive functioning at 3-month follow-up, and no change compared to controls and neurocognitive functioning at 1-year follow-up. Back to the chronic use study, all 4 patients had mild difficulty with attention and concentration, but we were testing them while they were smoking, which they did throughout the day, taking breaks from their testing to smoke when their symptoms required it. There was at least a minimal impairment of acquisition of complex new verbal material, but higher level executive functions were totally normal in half the patients. There were no depressive symptoms in any, and no attributable sequelae to cannabis. You would get similar or worse impairment scores on patients with the same kinds of chronic, intractable disorders, irrespective of drug use. We did imaging with MRI. One patient had age-compatible atrophy, I'm sorry. Patient B was normal, non-specific changes in patient C, and patient D had multiple sclerosis changes. However, unlike we expect over time, fewer lesions, plaques were noted from a prior scan of years earlier. So there were no attributable changes to cannabis. So that was, the testing was done in 2001. In 2018, I tried to do some follow-up. Obviously, the patients had aged, had we all in the interim. 3 of the patients had lost access to NIDA cannabis, but 1 continued daily use from other sources. 2 of the patients were reported to be cognitively intact via a nurse who had known them for a very long time. I interviewed 2 of the patients, and they were mentally sharp over the phone. Patient C was and is still an active vice president of an investment firm. So a high-functioning individual despite many grams of cannabis use a day. There have been some older studies trying to accumulate all the data. This one by Pope et al. Looking at neuropsychological performance in long-term users. They compared current and past heavy users with light users. And after a period of abstinence, some cognitive deficits were detectable in current heavy users for a week, like memory of word lists, but they were totally gone after a month. Quote, our findings do not support the hypothesis that long-term heavy cannabis use causes irreversible cognitive deficits. Again, keep in mind, this is chronic recreational use of cannabis showing no permanent damage after abstinence. Igor Grant et al., again, looking at neurocognitive effects of cannabis use and a meta-analysis. Quote, the results of our meta-analytic study failed to reveal a substantial systematic effect of long-term regular cannabis consumption on the neurocognitive function of users who were not acutely intoxicated. Quote, these findings are not likely to generalize to a more limited administration of cannabis compounds as would be seen in a medical setting. So again, it bears emphasis, as we have said repeatedly, that there's a big difference in dosage and risk of cannabis smoking recreationally as compared to lower doses, particularly with an oral formulation used for symptom reduction in the setting of illness. More recent study, most recent excellent study looking at cognitive functioning in adolescents and young adults. So again, this is recreational use. And over 2,000 cannabis users. It should be 69 studies. Mean age 20.6 years with over 6,000 controls. There was a small overall effect size for reduced cognitive function in frequent or heavy users. However, when abstinence occurred for 3 days, there was no difference between abstainers and users. Quote, all effect sizes in the study were below 1/3 of a standard deviation. Quote, previous studies of cannabis in youth may have overstated the magnitude and persistence of cognitive deficits associated with use. Reported deficits may reflect residual effects from acute use or withdrawal, or maybe they drank alcohol as well. Quote, these results do not support a heightened risk for poor cognitive outcomes in cannabis using adolescents compared with adults. Again, it could be a lot better if low doses were used with an oral preparation. Taken from Zach Walsh's study again, risk of harms, non-medical use, and violence, etc. This study of RECAN was looking at 150 patients with MS, spasticity, 150 patients in clinical trials, and 900 post-marketing after approval of the drug. An interesting phenomenon was the average doses, the number of sprays per day, was lower in real life use, um, ranging between 5 and 6.4 sprays a day as compared to over 8 sprays a day average in the randomized controlled studies. But effectiveness was maintained in the majority. They looked at 33 patients more specifically. Mean spasticity scores on 0 to 10 numerical rating scale decreased from 6, which is moderately severe spasticity, to 3.6, which is almost on the low range at the final visit, and that was very highly statistically significant. Again, problem that was cited as a risk before, that of suicidal ideation. There was one case in all the studies, but that was a patient on placebo. And there was no association with cognitive decline, depression, or significant changes in mood. At 6 months, 69% of the initial patients continued on the medicine, and 66% at 1 year, which is a good rate of adherence. Driving skills. So these patients were tested before and after Sativex use. The only significant difference, there was only one study that showed a decrease. This is in visual pursuit, but this is not statistically significant. The only change that was an increase in determination, meaning that the effort that the patients put in was better. So it was not possible to show any increased difficulty with driving because of Sativex use. More specifically, cognitive ability, looking at paced serial addition, Passat scores, You see that the bars, baseline and final visit, placebo versus nabiximols, Sativex, no significant difference. Now, how about clinical efficacy? The patient, physician, and caregiver global impressions of change were all markedly improved on Sativex over placebo. Looking at the Spanish registry, there was only a 2.4% incidence of significant psychiatric or psychotic event and 0% suicidal ideation. Switching to a study that was done of synthetically produced delta-8 THC in a pediatric population to treat nausea and vomiting associated with cancer in these kids, in 480 total applications, this is almost universally effective in allaying nausea and vomiting with minimal side effects, despite a very high dose, 18 milligrams per meter squared, as compared to 5 to 10 milligrams per meter squared as a suggested dose in adults. Issue of depression, looking at non-medical versus therapeutic use. In those, 7 of the therapeutic studies showed improved mood, and 1 reported positive association between depression and problematic cannabis use. Back to the chronic use study that we did, keep in mind, these are for patients with extremely severe medical problems. Looking at the Beck depression inventory scores, just for baseline, mild depression is 18, moderate 27, severe is 34. So patient A was a 6, not depressed, and patients B, C, and D rated 0. So this is really remarkable. Back to psychosis and schizophrenia, looking at associations in the different contexts. I really like this study because it does put it in context. So there are very good data from the National Health Service in the UK, and 600,000 visits per year, 2.3% of the total UK population between the ages of 16 and 44. Incidence and prevalence of schizophrenia was stable or declined between 1996 and 2005, despite estimated 18-fold increase in cannabis usage in youth over 30-year interval. Quote, the most parsimonious explanation of the results purported here are that the schizophrenia psychoses data presented here are valid, and the causal models linking cannabis with schizophrenia psychoses are not supported by this study. Similarly, from England, in male heavy cannabis users, the number needed to prevent schizophrenia ranged from 2,800 to 4,700, depending on age. What that means is you would have to stop 4,700 people from having any exposure to cannabis to eliminate 1 case of schizophrenia. In female heavy cannabis users, the NNP for schizophrenia range from 5,470 to 10,870. What we know at this point is if someone is pre-psychotic, destined to become schizophrenic, heavy cannabis use at a younger age will cause it to be expressed at a younger age. There remains no evidence of production of schizophrenia by cannabis in someone without prior susceptibility. Anxiety. Feingold looked at this. This was from survey studies in 3,723 Americans. A small percentage, 1.7% of patients had an anxiety disorder and used cannabis throughout. There was no significant difference in anxiety remission rates noted compared to other users and non-users. No significant difference in the three groups on suicidality, on quality of life measures, mean scores on emotional and mental health subscales and mental functioning were significantly higher in cannabis users than abstainers. Again, looking at cannabis use and anxiety with depression, nearly half of the anxious sample, which was 888 individuals, or 49%, reported substituting prescribed medication with cannabis. So to some degree, of whom 61% indicated that cannabis had completely replaced a drug prescribed. And most frequently, that was antidepressants or benzodiazepines. So we see here the percentage that replaced the prescribed medication with cannabis, 23.8% for antidepressants, 15.8% for benzodiazepines. Very good. An older study, they asked two experts, New York Times had this, looking at parameters of addiction for various substances. Now, arguably, the worst is nicotine. Everyone knows that's hard to quit. Heroin, very severe as well. Cocaine, alcohol, caffeine, and what's this? Cannabis is last. So a little bit higher on intoxication. That's the point of cannabis use recreationally, but really very low rates of withdrawal, reinforcement, tolerance, dependence, and addiction potential. And that's from experts. Again, looking at these kind of parameters, on top here, we've got the number of sprays per day that people use Sativex in the course of a year and a half. We see, interestingly, that from a start of 10 or 11 sprays a day, it actually went down over a year and a half to somewhere about 9. So no tolerance developed. Tolerance would indicate an increase in the number of sprays per day, and this actually went down. Patient had improvement in symptoms. Intoxication. Let's put this in context. These are visual analog scales of intoxication. 100 would be as high as you could possibly be. 0 is not at all. 80 is what patients would or people would want if they're trying to use cannabis for intoxication. 20 would be threshold, a point at which you feel something different. And looking at, there's no difference between Sativex and placebo on the intoxication scales at these low or moderate levels of usage. We did run into one abuse and attempted diversion effort. So this is a vial of Sativex, and you see the damage from trying to get inside, but the perpetrator was a little dog. And there's been no known diversion that we know of Sativex to the black market. Now, for the last section, we're going to talk about cannabinoid hyperemesis syndrome, which is a genuine contraindication to cannabis usage in people that have it. We published this study in 2021, and we'll go through in detail. But first, some review. So what is it? Well, this is a weird syndrome. The first person to have it began symptoms in 1996, but it wasn't identified until 2004. The people who had it all had a very stereotyped presentation. Users of chronic high-dose THC with an unusual constellation of symptoms and signs consisting of cycles of nausea, vomiting, and abdominal pain, accompanied by a weird behavior, chronic hot water showers or bathing, sometimes to the point of hours a day running out of hot water. Abstinence is the only definitive treatment, but application of capsaicin, the hot ingredient, and chili peppers may stop an attack temporarily. The largest case series before ours was at the Mayo Clinic with 98 patients. A review in 2018 documented 105 journal articles in hundreds of patients. The best study on what it's about was Devono in 2020. She noted phases of CHS, prodrome of nausea, vomiting, anxiety, and sweating, followed by vomiting episodes, hyperemesis with abdominal pain, and the compulsive hot water bathing. And if the patient becomes abstinent, recovery. A 2012 study, no doubt worse today, um, estimated the hospitalizations, other treatment and interventions might exceed $95,000 per patient before they got a diagnosis. Unfortunately, there have been at least 2 deaths attributed to CHS, not a direct effect of cannabis, but due to electrolyte abnormalities from the vomiting. It's important to note that standard antiemetics such as ondansetron and granisetron are poorly effective. Haloperidol intravenously is better, as is capsaicin on the skin, as we mentioned. From Devono's article, nice diagram of all the areas involved, particularly stress mechanisms leading that are involved in cannabinoid hyperemesis syndrome. So what she had hypothesized as possible reasons for this might be a biphasic nausea and vomiting response to THC. As we've said previously, at low doses, THC reduces nausea and vomiting. At excessive doses, anyone can become nauseated and vomit, but this is different. This is in chronic use. With chronic use, you would expect a downregulation of the CB1 receptor, and that could lead to paradoxical responses. She also noted activation of the hypothalamic pituitary axis. She pointed out there could be a genetic predisposition, which had not been defined as of 2020, and indicated that common myths like pesticide or neem exposure, these are unsubstantiated causes. This is a weird study that was done in New York City. The methodology was inexplicable to me. They interviewed patients at the Bellevue Emergency Department that came in for reasons other than cannabis and asked them about their cannabis use and whether they vomited with it and took showers to reduce it. So they created a new definition of CHS, not CHD. Um, uh, their estimation was that about 33% of heavy cannabis users might have CHS. And from that, they figured, like New York City is representative of the nation as a whole, that there'd be 2.75 million Americans with a diagnosis. A low estimate was 350,000. Let's split the difference and say that over 1 million people might be affected, and then recognition is going up. In our project, we hypothesized that it could be the genetic problem, which we assessed. Our main candidates would be mutations, what are called single nucleotide polymorphisms or SNPs, particularly affecting the CB1 receptor gene called CNR1 or the TRPV1 receptor because of the hot bathing and the capsaicin benefit, or the enzymes that break down THC. So the way to do this with genomic testing, which we pursued, we developed an extensive screening questionnaire to establish the diagnosis. This went through institutional review board, and we recruited for a year with 585 respondents. We used very strict criteria. They had to have all the symptoms of CHS, plus have been diagnosed with it and have ongoing symptoms. In other words, if somebody had been told that they had CHS and didn't have symptoms now, they were not included because they might have been misdiagnosed. So we were very careful about that. Of the 205, 99 agreed to get testing and were sent kits, but only 28 returned them. It's necessary at this point to indicate that we had a great deal of pushback from the CHS online community with active discouragement to take part in the trial and accusing us of being motivated by money and not knowing what we were doing. We also had 54 controls that were heavy cannabis users but didn't have CHS symptoms. 12 of them returned the kits. So between the survey, et cetera, this is the largest study of CHS to date and the only one to look at genomics. So if we look at what we got, CHS patients were high frequency users, 91% daily or more than daily, using flower or concentrates, median of 4 grams a day of THC predominant material. 15.6% have been told that they were cannabis dependent or addicted at some point, and over half had had withdrawal symptoms that would go along with that. The vast majority, 87.7%, got better after they quit using, but virtually always had recurrence after resumption, especially at a point where they had escalating dosage. Among the controls, the use patterns were quite similar. 100% had used cannabis within the year, 70% daily or more, and again, smoking high THC material. Only 3.7% had been labeled as having cannabis addiction or dependency, and 3/4 had never had withdrawal symptoms. Only 11% had ever been told to quit for health reasons. Demographics, I guess the real salient point here is we required that the control subjects not have CHS symptoms, so that's why the big difference is here. This is a table that looks at the various genes that were of interest or showed changes. 5 of these were statistically significant, and these are the odds ratios with confidence intervals. So if you see 12, it means that 12 times as many people had this mutation that were CHS patients as compared to controls. Some patients, there were, I believe, a couple that had all 5 of the mutations. Most had fewer than that. So the first gene we looked at was the CNR1, the CB1 receptor gene. And it's of interest to note that single nucleotide polymorphisms have been associated with cannabis use patterns in prior study, but were not significant in the cohort of the CHS patients. Now, this is an important distinction. There is another condition which can be mistaken for CHS called CVS, cyclic vomiting syndrome, in which there has been a CNR1 mutation noted. Cyclic vomiting syndrome often presents in childhood with a child who has episodes of unexplained vomiting and who has a positive family history of migraine and goes on to have more classic symptoms of migraine when they're older. Interestingly, cannabis helps this, but you can see how this would produce confusion. We think that testing would help make distinctions where people are confused by the historical overlap, if there is any, in fact. A gene that we hadn't figured is COMT, catechol-O-methyltransferase. So this is an enzyme that catabolizes, breaks down catecholamine, especially dopamine. Mutation with this RS4646316 was noted in the intron, the introductory part of the gene, in over half of the CHS patients, an odds ratio of 12, p-value of 0.012, compared to only 10% of controls. When there's a loss of function in this enzyme, this can lead to increased amounts of dopamine. That will lead to such symptoms as compulsive behavior, substance abuse, gambling, and even sex addiction. This particular mutation has been previously associated with depression, rumination behavior, and heavy alcohol intake at a younger age, particularly in women. Um, Variants display impulsivity, disinhibition, attention deficit, obsessive compulsive disorder, anxiety and psychosis, and may have cognitive impairment by cannabis. So these are all risks that people would have with this kind of mutation. One of our other hypotheses was a problem with the TRPV1 receptor, and we did find that. This mutation was observed in a downstream area of the gene in 71.5% of the CHS patients and only 30% of controls. TRPV1's been linked to anxiety and pain responses in the brain. It mediates long-term depression in the hippocampus and controls glutamate release in the solitary tract nucleus that affects gut motility and secretion. A prior study showed no polymorphisms in cannabis-dependent patients, but in these patients who are arguably dependent, we did. This specific mutation was not previously reported in the National Library of Medicine database, but its linkage to CHS, to mood and gut disturbances, as well as the hot water bathing and efficacy of capsaicin make a lot of sense given this result. We had also hypothesized possible problems with breakdown of THC in affected patients. And CYP2C9 is the main enzyme that affects breakdown of THC, but also anandamide and 11-hydroxy-THC. So we saw a homozygous mutation, 2 copies of this particular SNP in 46.4% of the CHS patients and only 10% of controls. So if this drug is underactive, it could lead to accumulation of THC and generation of that biphasic dose response towards having nausea and vomiting, or it might lead to abnormal metabolites that also could generate this kind of problem. A dual mutation of 2C9 with 2C19 was reported in a CHS patient who had a personality disorder and was cannabis dependent. Another mutation that we hadn't necessarily counted on was on DRD2. That's the gene that codes for the dopamine D2 receptor. There, we saw 60.7% of the CHS patients versus 20% of the controls had this SNP. DRD2 is the target of antipsychotic drugs, and drugs that stimulate it cause vomiting and also affect gut movement. Again, this mutation is strongly associated with depression and anxiety. Other mutations on this gene have also been associated with addiction to tobacco, to Tourette syndrome, and chronic pain. Now, since there was a problem with dopamine metabolism from COMT and also on the DRD2 gene, these are 2 genes related to dopamine that again help explain the nausea and vomiting and psychiatric symptoms in CHS patients. Finally, another one we hadn't thought of in advance, the ABCA1 gene or ATP binding cassette transporter. There was again a homozygous mutation, 2 copies in 67.9% of the CHS patients versus 20% of controls. This gene affects cholesterol and phospholipid homeostasis. It's associated with ApoE accumulation and A-beta deposition in Alzheimer's disease. Because of 2 copies in the CHS cohort, it could imply increased risk of dementia later in life. So this was a really new finding and possible risk factor for dementia, but also coronary artery disease and type 2 diabetes mellitus or additional risks. SNPs in a related gene, ABCB1, were associated with cannabis dependency, but we didn't see that gene affected here. So conclusions. We identified 5 mutations with plausible etiological roles in the phenomenology of CHS with statistical significance. All of these made sense in context. It wasn't like we found that CHS patients have blue eyes and it doesn't make any sense of the situation. We feel that the screening battery could be a helpful diagnostic for CHS susceptibility and might lead to lower costs for repetitive, fruitless tests or invasive tests like colonoscopies. And to quote from the study, cannabinoid hyperemesis syndrome can contemporaneously be conceived of not as a functional or imaginary gastrointestinal disorder, but rather as a manifestation of gene-environment interaction in a rare genetic disease unmasked by a toxic reaction to excessive THC exposure. Full disclosure, we have marketed susceptibility test to CHS, which is available at these links. We also have a CHS resource page, which can be accessed on the right, whatischs.com. And that's it for this module. So we'll stop sharing.
Thank you so much. That was excellent as always. So one of the things that really came through for me in this presentation is that so much of the research that has been done to date about adverse effects or risks associated with cannabis use is that it's all largely focused on THC-rich cannabis, and very little of it is on either well-balanced flower or optimized preparations. So how might this presentation have been different had it been with the research been done with balanced flower and with optimized presentation or preparations, excuse me?
Well, it wouldn't have taken an hour and 40 minutes to present it. I can say that much. Yeah, I think it's inarguable at this point that you can draw an equivalence between recreational cannabis use risks and those for medical use. Different animal. One indication of that would be looking at Marinol. If THC itself are really the problem, we should see a lot of people addicted or stealing Marinol. It just isn't the case. Yes, THC can be problematic when it's used in too great amounts, quite clearly. But we know exactly how to deal with this and harness it for therapeutic benefit.
Thank you.
Less is more.
So a lot of governments are very concerned about intoxicated driving. And one thing that I noticed is there was no conversation in that research at all about terpenes. And can you address for a moment how terpenes might improve or impair someone's driving?
Okay, so THC alone can be really scattering. In contrast, if there is alpha-pinene on board, you're going to reduce or eliminate the short-term memory impairment, which is really a big contributing factor to the intoxication or risk for driving. And anxiety is not going to help somebody's driving except make them perhaps drive more slowly. But that can be counteracted by CBD content, by limonene content, as we've just demonstrated in a study of Johns Hopkins that's about to be published, this being March 2024. Linalool, obvious reduction in anxiety. So there are many ways in which these so-called buffers to THC activity can make it a safer drug.
Thank you. So we know that the cannabis plant is a bioremediator, and where people are not using organic or regenerative cannabis growing practices, what concerns do you have about conventional grown cannabis, especially in the context of inhaled consumption?
Sure. So if there are heavy metals in the soil, they will get into the plant. And these pose particularly chronic use risks. Pesticides, again, we've gone into a lot of detail of the risks there. It's one reason that I think that this kind of testing for these contaminants should be mandatory, whether it be in the recreational market or medical market. Certainly, there are tight controls of anything that would be evaluated by the Food and Drug Administration to rule out these kinds of risks. It's just not something that's going to be allowed to slip through.
In the context of toxic psychosis, since that's relatively rare, do you think that that is really driven by genetics in terms of how people respond to cannabis?
Maybe, but number one would be the dose.
Mhm.
So I was present in Toronto when the first patient in that particular study, the Cellar study, had the toxic psychosis. This was someone who had never used cannabis and had psychiatric risk factors that shouldn't have allowed him in the study. He basically lied on screening. So, yeah, he was at risk for this because he didn't know what it was about and was a setup. However, the good news is, after some hours of observation and talking down, he was fine the next day, was discharged and with no sequelae. So, as bad as toxic psychosis sounds, we're talking about a self-limited condition and not one that makes you psychotic, crazy forever.
In regards to people who either have schizophrenia in their family and are at a high risk, or may have already been diagnosed with schizophrenia, how might they responsibly use cannabis? What advice would you have for them?
Uh, well, they could get tested for CHS susceptibility, and it would look at other risk factors at the same time. Uh, the advice in that situation is to avoid cannabis, or certainly non-smoked low dose use would be the recommendation if somebody felt that they had to try it or wanted to try it or needed it for medical reasons.
For schizophrenia?
Yes, yes.
Okay. All right, great. And then with regard to CHS, the work that we have been doing in this area is unique. Certainly, no one else has been able to identify that there is a genetic cause for this. And I'm wondering, why are more physicians not testing for this?
People may not like my answer. Modern American medicine, where you get an average of 9 to 15 minutes with a patient, isn't amenable to the kind of in-depth interviewing that's necessary to establish this kind of diagnosis. Um, so mistakes can go either way. In the past, there was a lack of recognition of CHS, so it was ignorance of the diagnosis. Now it can go the other way. A young person that comes in with nausea and vomiting, if they are asked if they've used cannabis at any point, they may get pegged um, erroneously as having CHS. So it's one reason that, number one, we need better interviewing. Um, and often this is the nurse that figures it out, not the ER doctor with no sleep who has a couple of minutes with the patient. And the other thing would be the screening test, as we mentioned, could sort things out. Maybe before the colonoscopy, barium enema or other interventions that are usually not bearing of fruit in terms of, it becomes a rule out. Um, Heretofore, this is what's known as a diagnosis of exclusion. If you had all these tests and you have nausea and vomiting and hot water bathing behavior and you're using cannabis, you've got CHS. We've added one element that may reduce some of the doubt.
Thank you. Well, it sounds like the moral of the story here is for people to be informed, start low, go slow, and not overdo it. Do
You betcha.
you have any final words before we conclude this module?
We'll certainly be talking about adverse events and other contexts and modules to come. We did want to provide this general overview of things, and I hope that people will appreciate the context and really understand the differences in dose and risks between recreational and medical usage.
Excellent. Well, thank you. This concludes our presentation.
My pleasure.